My name is Steffen Petersen. I'm a professor of cardiovascular medicine at Queen Mary University of London and a consultant cardiologist at Bart's Heart Center. After my presentation on CMR contouring and interpretation of derived results, you will be better able to discuss common etiology and pathophysiology to changes in ventricular morphology, appreciate that changes in ventricular morphology occur in patterns depending on etiology, and understand that ventricular morphology patterns depend on disease severity and can change over time. The heart is a compliant organ. As a result, the heart can respond to changes by adapting its chamber size and wall thickness. Such triggers that lead to adaptations in chamber size and wall thickness can be intrinsic to the heart, such as heart muscle disease or valve disease, or extrinsic to the heart, such as loading conditions. The left ventricle can dilate as a consequence to three common causes. Firstly, the heart muscle disease called dilated cardiomyopathy or DCM. Secondly, valvular incompetence, also known as regurgitation or insufficiency. The two most important examples are aortic regurgitation and mitral regurgitation. Thirdly, ischemic causes such as remodeling after a heart attack. The left ventricle can become thicker or hypertrophied as a consequence to three common causes: hypertension, aortic valve stenosis, and hypertrophic cardiomyopathy. Hypertension and aortic valve stenosis are related to the increased pressure the heart pumps against. In contrast, hypertrophic cardiomyopathy, or HCM, is an inherited heart muscle disease. The right ventricle can dilate due to pressure or to volume overload. Pressure overload can be related to pulmonary hypertension or pulmonary valve stenosis. Volume overload can be related to severe incompetence or regurgitation of the pulmonary or tricuspid valves. Congenital heart disease, such as the intracardiac shunt caused by an atrial septal defect, through volume overload can also lead to right ventricular dilatation. Right ventricular wall thickening or hypertrophy is caused by pressure overload, which is seen in pulmonary hypertension or pulmonary valve stenosis. Here's an example next to a normal heart of a dilated left ventricle with globally reduced wall motion and overall pumping function. The right side of the heart is normal in size, but there are valves that leak, namely we see mitral and tricuspid regurgitation. As a consequence to the mitral regurgitation, we also see a dilated left atrium. This combination is consistent with dilated cardiomyopathy or DCM. And here is an example next to a normal heart of a hypertrophied left ventricle. The hypertrophy is concentric in nature with increased wall thickness and LV mass. This form of LV hypertrophy could be due to hypertension, aortic stenosis, or hypertrophic cardiomyopathy. Concentric LV hypertrophy is rare in hypertrophic cardiomyopathy. HCM hypertrophy is more frequently asymmetric in nature. In this case, aortic stenosis has led to this cardiac remodeling. Importantly, these changes to the size of cardiac chambers or ventricular walls typically do not occur in isolation, as you could see in the earlier case of DCM. Another example of this fact is pulmonary hypertension. We just learned that pulmonary hypertension can lead to both dilatation and hypertrophy of the right ventricle. Similarly, severe hypertension can lead to hypertensive heart disease with LV hypertrophy and LV dilatation. So pattern recognition is important when determining the underlying etiology of such ventricular adaptations. Also, the clinical context is always important when considering changes such as dilatation or hypertrophy of the ventricles. Symptoms, signs on physical examination, or other hints from the medical history or medical tests may lead to strong suspicion of the cause of the cardiac remodeling seen on CMR. One last key point is that the patterns of remodeling, such as severity of dilatation or hypertrophy, can change over time with change in severity of the disease. So cardiac imagers should never just look at the images, but use all clinical information available. This will facilitate high-quality reporting of the findings, and this in turn will help the referring physician to optimally manage the patient.